Hello, and welcome to iDrop, the podcast of the Association of Caribbean Glaucoma Surgeons, where we shine the spotlight on glaucoma in the Caribbean. I am Desiree Murray, ophthalmologist and senior lecturer at the University of the West Indies in Trinidad and Tobago. Joining me today is Professor Leon Herndon, Professor of Ophthalmology at the Duke University Medical Center and Chief of the Glaucoma Division at that institution in North Carolina. Professor Herndon, welcome to the Caribbean.
Thank you, Dr. Murray. Great to be.
Okay. Professor Herndon, glaucoma affects over 60 million people globally, and the prevalence of glaucoma in the Caribbean is among the highest in the world. You have as one of your research interests the differential burden of glaucoma in people of African descent. Given our shared history, what are your views on the reason for this disproportionate burden?
Yeah, I think the disproportionate burden is multifactorial.
Mm-hmm.
I've done a lot of work in my career going in West Africa, for instance. A lot of work in Ghana in particular, going back to the late 1990s. We've done a lot of genetic studies. And we found that the rate prevalence of glaucoma is much higher in Ghana than in European-derived populations.
Yeah.
If you follow the diaspora from West Africa to the Caribbean to North America, you see that prevalence is still very prevalent. So I think it's a genetic basis. In fact, I played a really small role in a large study that was just published this year. It's a GWAS. And when we looked at that, we looked at the largest study in the African-derived population, about 11,000 patients, cases and controls that were spread equally. And what the study found was there were 46 new genetic loci that were associated with this population. And what we're finding is that this population hasn't been studied. About only 2% of all studies looking at genetics have included people from African descent. Even diseases like glaucoma that affects disproportionate African Americans, African-derived people. So I think it's just a start of finding genetic answers to these questions. But to address your initial question, I think it's multifactorial, but the genetic basis is truly a concern.
So we have an inherent predisposition to developing glaucoma.
Absolutely.
And it starts in West Africa, and it was transported because of our shared history with the forced migration of our ancestors to the Caribbean and the Americas.
Exactly.
Yeah, that's very interesting. But there are also factors that affect access to care in our populations as well that we might share. You have views on that?
Yeah, I mean, even if you control for access issues, we still see the prevalence is significantly higher in folks from the African-derived populations. So multifactorial, we have standard corneas and others. Access, sure, may be an issue, but we clearly find that the familial component is really a concern.
Okay, so my experience has been that patients with glaucoma present younger. They present with more aggressive disease, and as a result, they have advanced glaucoma at presentation. What we see often is patients blind in one eye and on the brink of blindness in the other eye. What can we as eye care providers do to address this tragedy?
Several things. I think the American Academy of Ophthalmology has recommendations about which age you should be screened at, 40 or 50. I'm like you. I see patients who present much younger.
Yeah.
So if you're African-American or Hispanic origin, I think by age 30, you should have your initial screening visit. So we need to get patients in sooner. We're doing something at the American Glaucoma Society where we're looking at family members because we know that if you have a family member or first-degree relative who has glaucoma, their risk is about 10 times greater of developing glaucoma than if you did.
Yeah.
So we have a process and a project going on in the American Glaucoma Society where we're going to take family members and allow them to share information with their first-degree relatives who hopefully will then get screened because that is the greatest risk if you have a family member. So I think there's so many things we can do to get patients and particularly potential patients in a lot sooner.
So you're articulating something that I feel strongly about, that screening in the high-risk populations. That's first-degree relatives, for example. But just like our population, screening is recommended because we have this genetic predisposition and we have a higher rate in our population? Because there are a lot of, there's a school of thought that screening for glaucoma is not something that is necessary. This is not something that's not my view, but I know that there's something along that line.
We've all been involved in glaucoma screening projects over the years. I'm sure you have.
Yeah.
Go to local churches where there might be a high risk, but the yield tends to be fairly low.
Yes.
And those particular suspects that you identify oftentimes don't follow up.
Yeah.
So there's a lot of problems inherent with any glaucoma screening process, even going to a high risk population.
Sure.
That's why I think, and I mentioned earlier in my talk, many times patients, family members bring them to clinic. So that is the greatest risk. That person in the room along with you and the patient was at the greatest risk. So I think that we concentrate on those at highest risk. But clearly, glaucoma screening, detecting patients earlier is going to be the key. I know you have patients you see every week who say, Doc, why did I come to you 10 years ago? I should have picked this up 10 years ago.
All right.
Then you left with not a lot of answers.
So opportunistic screening rather than the systematic population-based screening would have a higher yield.
Absolutely.
I agree.
Yeah.
Okay. So as persons of African descent, what can we do to reduce our lifetime risk of blindness? Screening is one, but anything else that you might suggest?
I think our population needs to be educated. They need to know the difference between glaucoma and cataracts. And again, I keep talking about the American Glaucoma Society because I'm past president. We're starting a big educational campaign, a big public awareness campaign. For instance, in the States, we have these commercials now. Henry Winkler was a popular actor. He played
Happy Days.
Happy Days, the Fonz.
Yeah.
And so he has a commercial about geographic atrophy, macular degeneration. And it's been very successful. But I have patients come to me every week and say, hey, do I have macular degeneration? Because of that commercial. I said, no, you don't, but I'm glad you're having that conversation. So we are going to start doing something like that in glaucoma, just increasing the public awareness. So potential patients will ask questions. So if you ask questions, then that's where the answers come.
Sure. And what about lifestyle diseases, lifestyle changes?
Well, we know, and I tell my patients that aerobic exercise helps.
Yes.
They lower the pressure by a point or two. They're happy to know that change in your diet probably doesn't make a big difference, so they're able to eat what they want to. But I think an overall healthy diet, healthy exercise program, it's going to be beneficial not just for the eyes, but for the whole body.
Okay. And that's a great note to end on. Lifestyle changes. What's good for the body is good for the eyes.
Yes.
So, Professor Herndon, it's been a pleasure talking to you at the 35th meeting of the Ophthalmological Society of West Indies here in the Trinidad and Tobago, the Caribbean. This has been iDrop, the podcast of the Association of Caribbean Glaucoma Surgeons. Together, we can end glaucoma blindness.